Hello, I am Jolie Long with the National Board for Certified Counselors. On behalf of the Medicare Mental Health Workforce Coalition, we would like to welcome you to our webinar today. Next. Before we begin, I would like to share some meeting details. Closed captions are now enabled and attendees can turn these on and off as desired. Interpreters can join the meeting via the phone number, ID, and passcode provided on this slide. A link to this PowerPoint presentation will be posted in the chat so that you can access the links on this slide. To receive continuing education credit, you must complete the session evaluation, including an attendance attestation. The link to the evaluation will be posted in the chat at the conclusion of the webinar. We will also send you an email with a link to the evaluation following the webinar. We will only be providing continuing education credit for live attendance. This webinar will be recorded and made available on the NBCC website and other coalition member websites for viewing purposes only. Due to the large number of attendees, the participants will remain in listen-only mode throughout the meeting. The presenters will be taking questions at the end of the session, so please feel free to type your questions into the Q&A box at any time. Next. This is the 12th Medicare webinar that the Medicare Mental Health Workforce Coalition has produced. Please find information for videos of the previous presentations via the link on this slide. Next. The Medicare Mental Health Workforce Coalition consists of organizations that collectively represent providers, clients, patients, and other stakeholders. Our overall mission is to increase access to client choice for mental health provider care. Together, we achieve this goal with the passage of the Mental Health Access Improvement Act. The coalition is now working to ensure successful integration of counselors and marriage and family therapists into the Medicare program. The coalition members are listed on this slide. Next. Today's webinar is titled Making Informed Decisions Before Submitting Claims to Medicare. We welcome two experts in the Medicare compliance field who will share information on how to adhere to the rules, regulations, and policies on billing documentation, patient privacy, and claim submission. They will share many resources and tips for properly submitting claims and setting you up for success in the Medicare program. I would now like to introduce our speakers. Their full bios are in the slides for your convenience. Next. Stephanie Portzline is the Manager of Provider Engagement for Novitas Solutions, Inc. and First Coast Service Options, the Part A and B Medicare administrative contractors for jurisdictions L, H, and N. She has served in various capacities in the Medicare program for more than 10 years. Next. Amy Ascher is a Part B Provider Outreach and Education Specialist for Novitas Solutions, Inc., with over 40 years of Medicare experience specializing in billing and claim submission, modifiers, telehealth/telemedicine, evaluation and management, EM, and preventative and behavioral health services. I now welcome Stephanie and Amy to begin their presentation.
Thank you so much, Jolie. And let me start by saying it is such a pleasure to speak to you today. A wide array of an audience I know that we have with us today. And I also am speaking to you for the second time. I believe I met with you all back in February to facilitate a collaborative presentation with the other MACs across the nation. So I was thrilled with the opportunity to come back and speak to you all again. And I've brought with me a tremendous subject matter expert, Amy Ascher, who's going to come along with me on this presentation today and share the wonderful wealth of knowledge that she has. So as Jolie indicated, today's presentation is making informed decisions before submitting claims to Medicare. Next slide, please. Before we get started, a quick disclaimer. Medicare program guidelines are constantly changing. The information enclosed in this presentation was current at the time that it was presented. This presentation is a general summary, which explains certain aspects of the Medicare program, but it is not considered a legal document. The official Medicare program provisions are contained in the relevant laws, regulations, and rulings. And you will see throughout today's presentation that we do provide you with direct hyperlinks for you to access the information that we are summarizing in today's presentation so that you can go back to the direct source that we are providing it from. Next slide, please. Outlined on this slide and the next within your presentation today is a listing of Medicare acronyms you can anticipate hearing us use throughout today's presentation. Please reference this listing to crosswalk the definition of each acronym as we progress through the slides. Next slide, please. And one more for me. All right, great. This presentation was created specifically with you in mind, with the intention of supporting counselors and marriage and family therapists as they navigate the new Medicare landscape. This webinar will provide an overview of best practice recommendations for pre-billing activities to ensure proper claim submission. This includes, but is not limited to, screening patient eligibility, determining the appropriate procedure and diagnosis codes, locating Medicare coverage policies, verifying coding and reporting accuracy, tracking the claim post-submission, and lastly, we'll conclude today with applying these approaches to a claim scenario and provide you with helpful resources to utilize after today's event. During today's presentation, you will often hear us refer to the term provider and not specifically a counselor or therapist. This term holistically encompasses Medicare participating providers, including those specific provider types. Next slide, please. So let's begin. We will begin today's presentation with a high-level review of the 5 elements of proper claim submission, as you can see in the graphic in front of you. Please note these steps are not all-inclusive and may vary depending upon provider type and the services rendered. Next slide, please. So to prepare today's presentation, we've reviewed the most common claim submission errors. And we've identified that deploying these 5 pre-billing activities we're going to review with you today will help mitigate improper payments and effectively reduce administrative rework and claim correction and/or resubmission. Starting with step 1, screening patient eligibility. Patient screening to identify the correct patient insurer, or sometimes multiple insurers, is a vital step to determining where to submit the claim. Moving on to step 2, determining the appropriate procedure and diagnosis codes. The provider's documentation determines the procedure and diagnosis code that should be submitted on the claim. It's also important to verify the coverage of the procedure code or service and that it is rendered by a certified medical professional within their state scope of practice. Step 3, locating a Medicare coverage policy. All services billed to Medicare must be medically necessary. Some services may have a local coverage determination, or LCD, or national coverage determination, or NCD, but not all. Next slide, please. Step 4, verifying coding and reporting accuracy. CMS developed National Correct Coding Initiative, or the NCCI edits, to control improper coding and inappropriate payments. It's important to review these edits to prevent claim denials prior to submitting your claims. The use of modifiers can sometimes indicate a service or procedure performed has been altered by some specific circumstance, but not changed in its definition or code, and it's also an option for claim submission and can be used to add information or change the description of service to improve its accuracy or specificity. And lastly, step 5, tracking a claim. Most providers fall into the Administrative Simplification Compliance Act, or ASCA, requirements for electronic billing. A claim must be filed with the appropriate Medicare contractor on a form electronic equivalent in accordance with CMS instructions. The payment floor establishes a waiting period during which time the contractor may not pay, issue, mail, or otherwise finalize the initial determination on a claim. It's important to include the specific type of documentation requested and respond promptly when addressing an additional documentation request when it is sent from any of the program integrity contractors, including your Medicare administrative contractor. And lastly, you have several options available to you as a Medicare provider to check claim status. Each MAC has an online provider portal, an IVR or interactive voice recognition system, and they also provide to you either through your clearinghouse or however you conduct your billing, an electronic remittance advice or paper. And those remittance advices provide detailed information regarding how your claim processed within the Medicare claims processing system. Next slide, please. So that was a high-level overview of what you can anticipate to hear throughout today's presentation. So let's review each of these steps in greater detail, starting with the first one, screening patient eligibility. Next slide. So insurance information can change for a Medicare beneficiary from visit to visit due to a number of circumstances. All providers should screen and verify their Medicare patients at each visit to obtain correct health insurance information before submitting a claim to Medicare. By performing this action, you prevent rejected claim and/or denied claims and ensure reimbursement from the correct insurer. This in turn results in faster payments and reimbursement to you if it's sent to the correct payer first time. Your front-end staff or office personnel play a critical role in the success of filing claims correctly and timely by helping to collect this information. Taking a few minutes with the patient or the patient's responsible party to collect the correct insurance information at every visit during the check-in process can prevent reimbursement delays. 3 common patient screening-related billing errors that we often see as a result of not performing this activity are Medicare Advantage plan denials, whereby the beneficiary is actually not enrolled in traditional Medicare and is instead enrolled in a Medicare Advantage plan. Medicare secondary payer or MSP denials, where Medicare was billed as the primary payer instead of secondary. And lastly, beneficiary eligibility denials, where Medicare was billed prior to and or after the beneficiary's Medicare effective date. Next slide, please. So what should you do prior to each visit? During patient registration, it's incredibly important to copy that Medicare card and or other insurance cards that beneficiary may carry. Verify the patient's name and the Medicare number on the card. The name used on all documents should match the Medicare card exactly. Although patient eligibility can be obtained from the Medicare card, sometimes there are scenarios where it may be beneficial to conduct some further verification. We'll talk about that on the next slide. For example, sometimes if a patient joins a Medicare Advantage plan and terminates their Part B Medicare coverage, they may still carry around that Medicare insurance card. So even though you're asking for the card, you've copied the card, they actually have a different insurance. So therefore, it's a best practice that you just don't use those cards as the only form of verification. We'll talk about a few other options you have available to you to verify the active insurance that each beneficiary has. Excuse me. And lastly, if you have a beneficiary that has approached you and is having some issues or some concerns with their Medicare eligibility and or needs a card replacement, et cetera, those types of inquiries are actually handled by the Social Security Administration. So you would want to redirect that beneficiary to contact them for further assistance, and the phone number is located on the slide. Next slide, please. So this is an example of what the Medicare card looks like for each beneficiary. A few years back, CMS conducted an initiative to replace HIC numbers that were formerly on the card and replace them with what's now called an MBI, or a Medicare Beneficiary Identifier. This identifier is no longer patient-specific, doesn't contain any resemblance to the Social Security number or any other personally identifying information, which is why CMS conducted this initiative. Excuse me. However, this number should still be treated as personally identifiable information. It should not be formally released outside of matters to conduct billing or eligibility verification for the beneficiary. A few important notes regarding how an MBI is generated. They will use the numbers 0 through 9 in uppercase letters. However, they do avoid certain letters, as sometimes they can be confused with numbers, such as the capital letter S, L, O, I, B, and Z. Next slide, please. Every year, CMS updates the Medicare deductible coinsurance and premium rates. These are released early on in the year, routinely through a Medicare Learning Network article, or MLN, which is listed on the slide for you. From a Part A standpoint, I do not feel that that's really applicable to today's audience, so we're going to fast forward to Part B. Excuse me. The annual deductible for Medicare Part B beneficiaries is $240 in the calendar year 2024. This is an increase of $14 from last year. Coinsurance remains at 20%. And if you need any additional information regarding any other, therapy thresholds or any other information, you can consult that MLN article that's presented on the slide for you. Next slide, please. So during the screening process, there's several questions you can ask a Medicare beneficiary. The first one there, I do not believe is applicable to today's audience, but here, just in case you need it. If you're in the Part A setting, which is more of a hospital-oriented environment, there is a questionnaire that CMS publishes that could be beneficial. But we're going to move forward to the Part B questions. Some questions you could ask: Medicare Part B medical insurance coverage, medically necessary services furnished by physicians and practitioners, preventive services, home health care, ambulance services, clinical lab and diagnostic services, surgical supplies, what we call DME, or durable medical equipment, and lastly, hospital outpatient services. These would actually be the services covered under Part B. I apologize, I think I skipped a slide here. Next slide. Okay, these are the questions that you should be asking. Forgive me. Here's that Part A questionnaire that I referred to. We're going to skip that, and we're just going to move to Part B, which is the second bullet here. So a few really great screening questions that'll get you to the root as to whether or not there could be another insurer in play. What is the beneficiary's marital status? Employment status? Are they seeing you as a result of an injury? And where did that injury occur? You should also be asking them, where are they currently living? Are they currently in a skilled nursing home? Are they in some type of home health episode? Next slide, please. I think I need, can you go one more for me? There we go, thank you. And also, could they be in a hospice setting? So do they have some type of terminal illness or life expectancy of less than 6 months? Or You can ask them, have they enrolled in some type of Medicare Advantage plan? Maybe you could give them a few examples of some local plans that you're familiar with to maybe get the dialogue or conversation going. Medicare Advantage plans are also sometimes referred to as Part C. So maybe using some of those variations of terminology would trigger the fact that the beneficiary may have a different insurer. We understand that sometimes when you're having these conversations, beneficiaries aren't aware that they may have multiple insurers. So it's really a best practice to try to use some of these key terms or terminology to maybe trigger that conversation, such as their living arrangements or, where did the injury occur, so on and so forth. Maybe, there's a workers' comp in play. Something along those lines that may trigger something additional that could be going on that may result in sending these services to a different insurer. All right, and one more slide for me, please. And as I indicated earlier, you as a Medicare provider have some options available to verify beneficiary eligibility. We would always recommend that you enroll into the Medicare Administrative Contractor's online free and secure provider portal that is offered. Not every MAC has the same portal. For example, the portal for Novitas Solutions is different than the portal for First Coast Service Options, Noridian, etc. There is nothing to prevent you from enrolling in each one, depending on where you provide services. But it is free. It is secure, and once you are enrolled, incredibly easy to access. And it provides you a wealth of information, not just patient eligibility. You can also use your individualized MAC's IVR system, which will also provide beneficiary eligibility information. You may also have access to this information through your billing agency, clearinghouse, or software vendor. They may have the capability of crosswalking it to a system called HETS, which you can see in the next bullet below. So they may be pulling in that information into their actual billing systems that you are leveraging. I will say that if you do call the MAC or utilize the IVR, you are going to need certain tokens of information from an authentication perspective in order to access patient information. And this would also apply to the portal. So basically something to remember: in order for us to give you info, you have to give us info to make sure that you have the right to basically access that information. All right, that concludes my section. I'm going to turn it over to you now, Amy. Next slide, please.
Thank you so much, Stephanie. Next is step 2, which is determining the appropriate procedure and diagnosis code. Next slide, please. Now, as we begin to review the coding section, I did want to advise that according to the site reference in the Medicare Contractor Beneficiary and Provider Communications Manual, providers are responsible for determining the correct diagnosis as well as your procedural coding for the services they furnish to your Medicare beneficiaries. Now, all Medicare claims, the documentation has to support the codes that are submitted to your MAC. Now, MACs are not allowed to assist with coding questions. For example, which procedure code would I use to bill for this type of service? These questions would need to be directed to the AMA. I did provide a site reference for you. In addition, please notate there are valuable resources and references listed to assist providers with proper coding. Next slide, please. CPT codes are used to report services to Medicare as well as other insurers, and they may also be referenced as a CPT Category 1 code. Now, the CPT code sets, they are published by the AMA once a year, so annually. So we do advise providers to check the AMA CPT public website throughout the year so you can obtain necessary updates to the CPT coding set. Now, CPT is a registered trademark of the AMA. There's also an AMA CPT physician resource that you can also use on the AMA's website, as well as purchase your CPT coding books. Lastly, one important aspect is to ensure that the code you are using is valid for the date of service billed and covered under the Medicare program. Because the CPT manual is updated annually, oftentimes from year to year, those codes, the terminology for those certain CPT codes could change. So that's why it's important that if you're billing for a 2024 CPT code, that you do use the most current manual. Next slide, please. Next, another important resource to assist you with coding and billing is the CMS HCPC manual. Now, CMS HCPC manual, it does contain a collection of codes and descriptors that represent procedures, supplies, and products and services. Again, the HCPC code is very similar to the CPT code, meaning it is published annually. So again, we do advise you to check the AMA's website throughout the year to obtain the necessary updates to those HCPC codes. In addition, there is general information on the CMS website that does direct you to valuable references. And that information is very helpful if you need additional information on HCPC coding. Next slide, please. Your diagnosis code. Your ICD-10 CM is a standard transaction code set, and that is for diagnostic purposes. And this is to track healthcare statistics, disease burden, quality outcomes, mortality statistics, as well as billing. There's also a valuable reference to assist providers with ICD-10 coding, and that reference is available to you on this particular slide. Our next slide talks about modifier. So once you determine what CPT or HCPC code to bill, the next item you need to consider is, do I need to report a modifier with this code selection? A modifier does provide the means to report or indicate a service that has been performed, has been altered by some specific circumstance from the procedure code definition. However, the definition of the procedure code has not changed. Now, modifiers do enable healthcare professionals to effectively respond to payment policy requirement. Next slide, please. Modifiers should be appended to the appropriate CPT or HCPC as appropriate. And these are reported in item 24D on the CMS 1500 claim form or the electronic equivalent. Now you will notice the payment modifiers listed. These modifiers are listed to assist you with billing. Because these are payment modifiers, they always need to be reported in the first position on your claim. Following that payment modifier could be an informational modifier. Now, they do provide additional information, however, it doesn't affect the reimbursement. So those could be listed in the second, third, or fourth position of your claim. Next slide, please. In preparation for today's webinar, we did receive a question regarding referring and or ordering physician information. I wanted to review these definitions with you. A referring physician is defined as a physician who requests an item or service for the beneficiary for which payment may be made under the Medicare program. Now, an ordering physician is defined as a physician or, when appropriate, a non-physician practitioner who orders the non-physician services for the patient. Now, the purpose is to provide Medicare services that are a result of a physician order or referral when the ordering physician is also the performing physician. I also wanted to mention to provide incident to services. Services and supplies are integral to the patient's normal course of treatment, and the physician or other listed MPP personally furnish an initial service to which the auxiliary personnel services are incidental. Now, next, you may be wondering, well, where do I put this information on the claim? Next slide, please. This information is reported in item 17 or the EDI equivalent. So item 17, you'll enter the referring or ordering physician. If the service or item was ordered or referred by the physician, all physicians who order services or refer Medicare beneficiaries must report this information. You'll leave item 17A blank. You will notice that it is grayed out. So that means you don't use that field. Followed by item 17B. There you're going to enter the NPI of the referring, ordering, or supervising physician or non-physician practitioner that is listed in item 17. Now, all physicians and non-physician practitioners who order services or refer Medicare beneficiaries need to ensure that they report this information on their claim. Next slide, please. So now you may be wondering, well, how do I find out how much I'm going to get reimbursed for a particular service? Well, CMS does have a physician fee schedule, and all the MACs will have that information available, but CMS also has that information available to providers. The CMS physician fee schedule lookup tool, as well as your MACs, will provide your Medicare payment information. So it's going to give you your pricing, your single code cert, where you can key in a specific code. It's going to give you fee schedule detailed information, as well as general status indicator. And some great news, the reference guide that I've listed will go through each one of the fields on the physician fee schedule on the CMS website. And again, I also recommend visiting your MAC's website for more information. Next slide, please. Now let's take a moment to review several other valuable resources to assist MFTs and MHCs with locating coding information. MFTs and MHCs can bill Medicare independently for their services furnished for the diagnosis and treatment of mental illnesses. CMS has a dedicated page which assists providers with various topics. You will notice the heading listed under the fourth bullet. It states where you can find information about Medicare covered services, and it does list valuable resources. So what I recommend is that you go out to the CMS webpage and review those valuable resources. They are going to help you with billing your services. In addition, I'm going to review some other helpful resources to assist you as well. Next slide, please. The CMS MLM booklet titled Medicare and Mental Health Coverage, it does provide detailed information. It goes through the eligible providers. It lists all their qualifications. So this would include MFTs and MHCs. It goes through coverage as well as the payment criteria. In addition, the booklet will outline double asterisks to advise you that codes can be billed by MFTs and MHCs. So those are some suggested suggested codes that MFTs and MHCs can bill. Again, they are designated with the double asterisk. So let's take a look at some of the recommended codes on the next slide. So CMS did provide the codes, several codes for MFTs and MHCs. And you can see by the double asterisk, these are the codes for your HBAI. And that's going to advise you that these codes can be billed for your MFTs and MHC. So those are going to fall into your health behavioral assessment and reassessment code. Now, shortly, we're going to discuss add-on codes and the importance of billing an add-on code in addition to your primary code. So we'll discuss that shortly. Next slide. Thank you. I wanted to talk about telehealth services. Telehealth services, they are visits with the provider that uses telecommunication systems with audio and video capabilities. And this is between a provider and a patient. The use of the interactive telecommunication systems does substitute for your in-person encounter. Now, there's two terms that I wanted to bring to your attention. The first one is distance site. That is going to be the location where the provider is. So wherever that provider is rendering services, that is referred to as a distance site. Where your originating site is, that's going to be the patient's location. Now, the use of audio-only equipment to furnish services is described by codes for audio-only telephone services and for your behavioral health counseling and educational services. Probably the most important point on this slide is the list of telehealth services. Some great news beginning January 1st with dates of service on or after January 1st. MFTs and MHCs were added as a distance site healthcare professional, which means they can render their services via telehealth. So as long as that code is on the telehealth list and it is within the state scope of practice, they can bill for those services. On our next slide, we're going to discuss the telehealth service list itself. So the first thing you'll see again is a link to the telehealth services. You're going to notice two categories for coverage. The first one is permanent and the next one is provisional. Permanent means those services will remain on the telehealth listing. Now you'll also notice services that are listed under provisional. They are going to have some refinements to telehealth policies based on current provisions. These codes were previously identified as temporary. Another important point I wanted to raise is the title or the column that you see that says, can the audio-only interactive meet the requirement? If it has yes, that means that service can be done through a telephone. However, if it has no, you need both audio and video. The other point I wanted to mention is oftentimes we do receive questions that although the minimum requirement is just through the phone, can I use both audio and video? And the answer to that is yes. So if it has a yes there and you want to do both audio and video for those particular codes, that is perfectly fine and you can bill that service accordingly. Now, we do ask the providers you do review that telehealth listing to ensure proper billing and coding. You also notice on the list, the HCPCS code is listed as well as your short descriptor. So that just gives you an indication of what the code is and how you are to bill it again and perform it, whether you need audio or both audio and video. And again, that is designated by the column, can audio only interaction be met? Again, if it has yes, it can be done through the telephone. If it has no, then that means you need both audio and video. Next slide, please. Next, I did want to touch on place of service when reporting telehealth services. So for dates of service on or after January 1st, 2024, when billing telehealth services, you'll use place of service 02 or 10. So either one of those can be used. Now the key is where the patient is. So place of service 02 is telehealth provided other than in the patient's home. So that's going to be the location where the health services or health-related services are provided or received. And that's going to be through telecommunication technology. The patient is not located in their home when receiving health services or health-related services through the telecommunication technology. Whereas place of service 10 is telehealth is provided in the patient's home. So this is the location where the health service and health-related services are provided or received through the telecommunication technology. However, the patient is located in their home which is the location other than the hospital or other facility where the patient receives care in the private residence when they're receiving health services or health-related services through telecommunication technology. And I wanted to also mention that beginning January 1st, telehealth services that are provided in the home, they're paid at the non-facility rate. Prior to January 1st, providers were to bill claims using telehealth, and the place of service they were billing was the place of service equal to what it would have been had that service been done in person, and they were to append modifier 95. Remember, the rules have changed beginning January 1st that you'll just report your O2 or 10 place of service. Okay, for our next section, I'm going to turn things back over to Stephanie. Thank you.
Thanks so much, Amy. What a great wealth of information. So now we're going to switch gears from procedure and diagnosis code identification to locating Medicare coverage decisions. Next slide, please. In general, covered Medicare services are considered medically reasonable and necessary to diagnose and treat a beneficiary's individualized condition. Medicare considers a service to be reasonable and necessary if it is determined that the service is safe and effective, not experimental or investigational, appropriate, including the duration and frequency that is considered appropriate for the service in terms of whether it is furnished in accordance with accepted standards of medical practice, furnished in a setting appropriate to the patient's medical needs and condition, ordered and furnished by qualified personnel, including one that meets but does not exceed the patient's medical need, at least as beneficial as an existing and available medically appropriate alternative, and a service can be considered non-covered for many various reasons. Let's explore those on the next slide, please. The Social Security Act screens payment and denies it for types of care or specific items, services, or procedures that are excluded by any statutory clause and meet technical requirements outside of coverage, but are determined to be any of the following: not generally accepted in the medical community as safe and effective in the setting and for the condition for which it is used. Not proven to be safe and effective based on peer review or scientific literature, considered experimental in any capacity, not medically necessary in the particular case or function it's intended to be used for, furnished at a level, duration, or frequency that is not considered medically appropriate, not furnished in accordance with acceptable standards of medical practice, and not furnished in a setting appropriate to meet the patient's medical needs and or condition. Above all else, anything that would be considered convenient or for cosmetic reasons, Medicare would not consider that to be a medically necessary service. Next slide, please. So also underneath the Social Security Act, CMS and its contractors may develop standards outlining what is reasonable and necessary for coverage under Medicare. From a Medicare administrative contractor standpoint, this is called a local coverage determination. Local coverage determinations, or LCDs, serve as administrative and educational tools to assist providers in submitting correct claims for services covered by the Medicare program. But keep in mind, LCDs are specific to the jurisdiction managed by the MAC. So for example, if Novitas Solutions develops an LCD, but Noridian does not have that same LCD, a provider should not be using, if a provider is in Noridian's jurisdiction, the provider should not be using Novitas's LCD as a form of guidance. They should be deferring to whatever Noridian is publishing. CMS provided us with guidance that we can no longer place ICD-10 codes as well as procedure or CPT codes physically within the LCD itself. Therefore, local coverage articles were developed as companion billing and coding documents, and that is where you will see a majority of that information listed, which includes billing and coding information and guidelines. If we have non-reasonable and necessary language, so excluded coverage, it will serve as a companion to an LCD, or the MAC may publish a local coverage article as a standalone form of guidance. The local coverage article will include ICD-10 diagnosis codes, CPT, and HCPCS codes as applicable, and it will also include responses to comments submitted on the proposed LCD. Next slide, please. Alternatively, at the national level, CMS will publish what are called National Coverage Determinations, or NCDs. And these establish nationwide coverage for an item or service. CMS may publish NCDs due to inconsistent local coverage policies that have been initiated by the MACs. If the service represents a significant medical advance in the field and no similar service is currently covered by Medicare, if the service is subject to substantial controversy, and lastly, if there is potential for rapid diffusion or overuse. NCDs can be found on the CMS website, and we'll go through how to find them here shortly. Next slide, please. So information that you could find within a national coverage determination, or NCD. The benefit category that the service or procedure is covered with under, item services descriptions, indications and limitations of coverage and or medical necessity, any specific claims processing instructions or submission details, national coverage analysis, transmittal information, historical revision history, any additional information that may be applicable, procedure codes, and covered and or non-covered diagnosis codes. Next slide, please. So it's important to understand that MACs and CMS do not develop a local coverage determination, or LCD, or a national coverage determination, or NCD, for every service or procedure that is covered under the Medicare program. Absence of an LCD or an NCD does not insinuate non-coverage. Providers should report services rendered appropriately, and unless statutorily excluded, payment is made for services that are considered medically reasonable and necessary, and only when provided by certified medical professionals within appropriate settings. A service or procedure can have other policies or guidelines besides an LCD or NCD, and this is not an all-inclusive list, but these other references may provide further insight and billing and or coverage guidance. These include National Correct Coding Initiative edits, medically unlikely edits or MUEs, references within the internet-only manuals or associated Medicare Learning Network articles, and lastly, the physician fee schedule. You should be aware of the coding requirements for the procedures that you bill, and Medicare relies on providers to report services appropriately, so payment is made only for services that meet the general definition of medically reasonable and necessary. Next slide, please. So how can you determine whether or not there is a coverage policy that exists for the specific service or procedure that you are rendering? CMS provides a Medicare coverage database search tool on their website. Link is directly on that slide. There's a keyword item that you can leverage. You could use diagnosis codes, procedure codes, types of providers, etc., and search using that keyword option. And then over on the right side next to keyword, you also have further refinement opportunities, such as you can drill down to the specific state that you rendered the service in. For example, we selected Texas here. Next slide, please. When you conduct that search, you can see on the slide, you have varying refinement options. You could do the state. You could select the contractor that you're specifically looking for. And then you also have all of these options over here on the right-hand side to further refine the search depending upon the specific type of coverage that you are looking for. So for example, you could further drill down to just NCDs and LCDs and ignore all other information. This will further help you refine your results if necessary. Next slide, please. All right, back to you, Amy.
Thank you, Stephanie. So we are going to begin with the National Correct Coding edits. So next slide, please. CMS did develop the NCCI coding edits, and these are referred to as NCCI. I'm sure Stephanie mentioned this several times to you. So let's go through it in a little bit more detail. Now, CMS did develop the NCCI edits, and this was to promote the national correct coding methodologies, as well as to control improper coding that leads to inappropriate payment. And the purpose is it applies to the coding policies that are defined in your AMA, CPT, national and local medical policy, and edit coding guidance that are developed by national societies, standard medical and surgical practices, and current practices. There are 3 components for NCCI. The first one is your procedure to procedure code pairs. So when you bill 2 different procedures on the same date of service for the same patient, your add-on codes, that's going to be your primary, as well as your add-on code that we're going to get into in a little bit more detail shortly. And your medically unlikely edits, known as your MUs. And that applies to your units of service that you bill either on a line of service or a date of service. I'm going to show you the Medicare booklet that CMS developed a picture of it and where you can find it. But there is a great resource that is available, and I did provide the link for you. Next slide, please. Now, earlier we did review some important coding references for MFTs and MHCs. Several of the codes do contain add-on codes. So let's review the definition and purpose of add-on code. Now, an add-on code is a HCPCS or CPT code that describes the service, and it is always performed in conjunction with another primary service. So primary and add-on code procedures need to be reported on the same claim for the same date of service. Remember, if the primary and add-on code is not included on the same claim for the same date of service, your add-on code will deny. So please save time in future denials and just submit them all on one claim. Now, AOCs are eligible for payment as long as they're reported with the primary procedure and it's medically necessary on the same date of service on the same claim. They are organized into 3 separate payment groups. Your type 1, those are codes that are identified in your CPT, HCPCS, or other CMS policies that define primary procedures. Type 2 are your add-on codes that are developed by contractors. And type 3 are your add-on codes with primary procedures, and those are specifically identified and defined in the CPT coding manual. Now, please note for NCCI, these are updated on a quarterly basis. So all 3 of the components I mentioned, your PTP edits, your add-on codes, and your MUs, they are updated on a quarterly basis, January, April, July, and October. Next slide, please. Now, you may be wondering how to locate your AOC. This is a snapshot of the CMS page that has detailed information, and it provides links to the most current files. So on the left navigation side, you will see, it's highlighted in green, Medicare NCCI add-on code. Right next to that, you're going to see the related downloads. So that's going to give you the most current file based on that particular quarter. So right now, what I have highlighted for you, that is the most current quarter. And to the right, it just defines your add-on code type 1, 2, and 3. Next slide, please. So when you do download the file, here is an example of what the file will look like. So let's say our provider is billing the HBAI services. They're billing 96158 and 96159, and they're trying to determine, well, is this an add-on code and what do I need to do? The first thing you're going to do is download the add-on code file. Once you do that, in column A, it's going to give you the types that we did review. Column B is going to give you your add-on code. Column C will give you a delete date if that was deleted for some reason. Column D is going to give you your primary code. And then F is going to be the edit date, and C is going to be your, or G is going to be your deletion date. Now you will notice in column H, there's special instructions. So if something occurred with that code pair, that will be notated as well in that column. Next slide, please. Next is a step-to-step booklet that CMS has that stresses the importance of the NCCI process. So if you're looking for detailed information relating to the NCCI program, this publication is an excellent resource that will walk you through each one of those components of the NCCI program. Next slide, please. Finally, our last step is tracking a claim. Next slide, please. So now you may be wondering, why are providers required to submit claims to Medicare when they see a Medicare beneficiary? So earlier we mentioned the ASCA requirements. ASCA is the Administrative Simplification Act, and the act does require that all claims for reimbursement under Medicare, except for small providers, be submitted electronically with limited exceptions. Now, providers may submit via 1500 claim form if you meet the exceptions for filing your claims on paper. Medicare will not accept claims submitted on paper that do not meet the limited exception criteria. Claims denied for this reason will contain a claim adjustment reason code and a remark code on your remittance advice, indicating that the claim will not be considered unless submitted via electronically. Now, an example of an exception would be for a provider of service with fewer than 10 full-time equivalent employees. Our next slide talks about claim filing limit. So to ensure timely reporting of your Medicare claims, claims must be submitted no later than 12 months or 1 calendar year after the date the services were furnished. Medicare secondary payment claims do not receive timely filing extension. Claims received by the contractor without an explanation for the late filing are generally assumed to be filed late, and the provider does accept responsibility for that late filing. Next slide, please. Medicare regulations, and I did provide the site reference for you, allow for the following exceptions to the 1-year time limit for filing fee-for-service claim. They include administrative errors, retroactive Medicare entitlement that involves state Medicaid agencies, retroactive disenrollment from a Medicare Advantage plan. The Medicare contractor has the responsibility for determining whether a late claim may be processed based on all the pertinent documentation submitted by the provider. And you will notice we provided many site references to assist you with claim filing and timely limit exceptions. Our next slide discusses the payment floor. This does establish a waiting period during which time the contractor may not pay, issue, or otherwise finalize the initial determination on a clean claim. A clean claim is one that does not require the MAC to investigate or develop on a prepayment basis. The payment floor date is the earliest date after receipt of the clean claim that payment may be made. Medicare has 30 days in which to pay the claim, but cannot pay before the payment floor. So if you bill electronically, the good news is the payment floor is only 14 days, which means Medicare could release your payment between 15 or 30 days. Again, it depends if we need additional information to process that claim. However, if you bill on paper, your claim could take 30 days before your payment is released. Also, we do ask to avoid duplicate submissions, that you do allow sufficient time for a claim to process, and check claim status of the claim prior to resubmitting your claim. Next slide, please. Now, once your claim is received, it begins to process through the Medicare system. So there may be situations that Medicare needs additional information to process your claim. These are referred to as ADRs, Additional Development Requests, and they are used to collect and clinically review medical records and related information. And this is to ensure that your payment is made only for the services that meet all Medicare coverage, coding, billing, and medical necessity requirements. An ADR is generated by the contractor when the documentation is necessary to support a claim. The request for the medical record documentation to support payment of an item or service reported generates when documentation is necessary. The ADR does include a description of the type of documentation that is needed, along with the date of service. And providers have 45 days to submit medical records to support their services. When you do return your ADR request, please ensure that the ADR letter is used as the cover sheet, accompanied by the necessary documentation, and you can use one of the submission options that are outlined below. We did provide those methods for you. There's also a reference to the medical review area that you can review for additional information on the ADR process. Next slide, please. Claims that are submitted for Medicare reimbursement consideration will be processed under the potential outcomes. First, it could be approved to pay. That means a claim determination for the item or service covered by Medicare resulted in the Medicare reimbursement. However, a denial would be a claim determination showing the service or item is not covered by Medicare. The resolution is to determine the reason for the denial from the remittance advice. A rejection is to correct and resubmit or adjust, and that means no claim determination can be made. So the resolution is to review your claim, correct it, and then resubmit it to us. Next slide, please. Now, once a claim has been submitted and assigned a control number, there are easy and affordable ways to track claims processing. First would be the MAC portal that Stephanie reviewed with you earlier, as well as the MAC interactive voice response system. As she mentioned, there are authentication things that you need to do for using both. You can also review your ERA, which could be paper or electronic. Using these tools can also assist with determining why a claim was returned, denied, or rejected, and does assist with trying to prevent the claim submission errors from occurring next time. Now I'm going to turn things back over to Stephanie. Stephanie?
Thank you so much, Amy. So now that we've covered the 5 elements or steps prior to claim submission, let's apply them to a billing scenario. Next slide, please. So Amy, a patient has been referred to a mental health counselor for a health behavior assessment and intervention. The mental health counselor has rendered the service. What should he or she do next?
Well, as Stephanie reviewed earlier, step 1 is to screen the patient for eligibility. So the MAC portal will advise you if the patient is entitled to Part B and does not have a Medicare Advantage plan on file. It'll also let you know if the patient has met the 2024 deductible. If there's MSP information, that's going to reflect that Medicare is primary. If there is no home health certification or care on file, and the patient is not enrolled in hospice. So it is best practice to always ask the patient if anyone is coming to their home to assist with his or her care as a beneficiary. Beneficiaries are often not familiar with this terminology. Next slide, please. Now, step 2 is determining the appropriate procedure and diagnosis code. So as Stephanie mentioned, our example, the MHC is providing a health behavior assessment. The ICD-10 code is the standard transaction code set for the diagnostic purposes. So you need to verify the code prior to submitting the claim. Now, our example shows the total time for the HBI service was 42 minutes. We review the documentation and we're thinking about billing 2 codes. 96158, the code is listed for 30 minutes, and 96159, which is our add-on code. And this part of the service was performed for 12 minutes. So remember, the total time for the HBAI code was 42 minutes. So code 96158, you're going to bill that on a single calendar day for the first date of service, procedure code, and a unit of 1, and followed by 96159, which is your add-on code that needs to be reported with the primary code with a unit of 1, the date of service, and the appropriate CPT code. One point I wanted to mention is the rule for billing time codes for a single time code is that if you bill less than 8 minutes, you cannot bill for that particular code. Our next slide is the CMS Medicare coverage database. And as Stephanie showcased earlier, it does show you your national coverage determinations, local coverage determinations, and many other valuable resources when you're performing your search. So you're simply going to click on the Medicare coverage database search tool. First, enter the keyword and select the MAC state. The next search will populate your results. So if you're looking for your LCDs or LCAs, you can then search the type of document you would like to review by checking those boxes. Now you will notice we did select the NCDs or NCA and NCDs. So once you apply, if the documents are provided, it will populate. And please make sure you do enter your state so it gives you the most beneficial result. And this will help you review the most current policy for your search. On our next slide is step 4. So as we determined in step 2, the provider is billing CPT codes 96158 and 96159. So step 4 is to verify coding and reporting accuracy. So because the provider is billing 96158 and 96159, the code pair is listed as an AOC type 1 code, and that is identified in column A. Column B is your add-on code. Column D is your primary code, and you will notice that the effective date is listed there for you as well. Now your AOC are services eligible for payment, again, but they have to be reported with your primary procedure on the same claim for the same date of service. Our next slide is our final step to tracking. So once the claim is submitted for processing and it is assigned a controlled number, you should begin to track the claim. So again, there are several options that are available: your MAC online portal, your MAC IVR, your remittance advice, whether that's paper or electronic. Please be aware of your payment floor. Remember, that is the earliest day after receipt of your clean claim that a payment can be made. Electronic claims have 14 days from the date of receipt, where your paper claims have 29 days from the date of receipt, and Medicare has 30 days to pay the claim, But again, they cannot pay the claim before the expiration of the payment floor. And again, there is a claim status request response document that you can review. The 5-step process is extremely important when billing for Medicare claims. So next, I'm going to turn things back over to Stephanie. Thank you.
Thank you so much, Amy. So we're going to conclude today's presentation with a few helpful resources for you to consider. Next slide, please. So how can you obtain assistance with Medicare-related questions after we conclude today? Well, number one, I would encourage you to determine who is your MAC. And the best way to do that is to go to the CMS website, which is www.cms.gov, and type in the word MAC, M-A-C, and you're going to see a variety of resources pop up, but one of them is going to be who are the MACs. Click that resource and you're going to be able to find a beautiful jurisdictional map that outlines who the various contractors are for each state. So I would start there. Identify who your MAC is. And that's going to be beneficial because that's going to drive you to access the resources that are outlined on the slide in front of you. But I will tell you, at the end of the day, each MAC has the various resources that you see in front of you. They have a customer contact center and an IVR. And the contact center is positioned with representatives who are there to help you. The IVR is a fantastic resource when it comes to being able to systematically query for information, claim status, appeal status, etc. You can also use the web chat function. Now, I will tell you not all MACs offer this function. You'll know if it exists by visiting the MAC's website, and you'll see a prompt pop up on the website asking if they can help you. It's just another form of interaction for you to be able to get assistance. And lastly, you do have the option to submit what's called a general inquiry. Full disclosure from a general inquiry perspective that the MACs have up to 45 business days to respond. So although it is an avenue and a channel for you to obtain assistance, it is not the fastest. Next, you also have websites. Each MAC, as well as CMS, has a website that contains a plethora of information, including informative articles and interactive self-service tools. And lastly, something near and dear to our hearts, obviously, this is what Amy and I do, educational resources help you stay in the know. Every MAC offers live educational sessions, either virtually or in person, as well as on-demand options for assistance or education, and those include videos or webinar recordings. And lastly, each MAC does offer a listserv or an email of some fashion. We may refer to it in different terminology, but I would encourage you to subscribe to it. We do not blast you with information. There is a cycle that we use for distribution. For example, Novitas, we issue ours on Tuesdays and Fridays only. And it's really a great resource to stay current and in the know. We summarize updates for you. So it's a quick and easy read and really keeps you current. So I would encourage you to peruse each of those resources within your respective MAC. All right, next slide, please. All right, so this slide basically outlines the key takeaways from today's event. And in summary, we did review the 5 critical steps providers should be taking before submitting a claim, which includes screening patient eligibility, determining accurate procedure and diagnosis codes, identifying Medicare coverage, verifying coding and reporting accuracy, and lastly, tracking that claim to finalization. I hope you found this to be valuable. And I will now turn it back over to Jolie.
Thank you, Stephanie and Amy, for sharing your time, knowledge, and immense expertise with us today. This critical compliance information along with the resources, all the links and resources that you've shared, the tools and the tips. They're sure to help counselors and MFTs bill for Medicare services in the correct way, and hopefully increase the likelihood of being reimbursed quickly and with less effort. Hopefully, this will alleviate any anxieties around the administrative aspects of working with older adult clients. You've provided really crucial information to help us bring care to older adults that is so desperately needed. So we definitely appreciate your partnership with the counselors and MFTs who are quickly becoming an integral part of providing services to Medicare beneficiaries. Last I checked, I think we had 38,000 counselors and MFTs enrolled as of since January 1. So they're definitely enrolling in the Medicare system. So we do have a little bit of time left for some questions and answers. We're going to move on to that now. We'll kind of sift through these and get through as many as we can, as many as you are able to answer. We're not going to obviously get to all the questions, but we will take as many as we can. So I'm just going to read some of them out and let you all decide who would be the best person to answer those. So I'm going to start with this one, and it is, am I understanding the document correctly that marriage and family therapists and mental health counselors appear to be only able to use health behavior intervention CPT codes as opposed to the usual psychotherapy 90837, et cetera, codes that we use with other payers. So are you all able to address that coding question?
Sure, no problem. Sorry, I had a little bit of issue.
Trying to get off mute too. Go ahead, Steph.
Apologize for that awkward silence. And Amy, please fill in if I misrepresent. It might be helpful if we could navigate back to give me 1 second, slide 30. So this booklet is fantastic, and it does outline the services that marriage, family therapists and mental health counselors can provide. So if we go to the next slide, please. You'll see here that MFTs and MHCs, there will be a double asterisk next to the codes that CMS is allowing these types of providers to provide. Amy, anything you want to add to that? I know we had lots of questions in the chat.
Yes. Now, there are situations where certain services can be done incident to, but that means both the physician and the MFT or MHC would have to be in the same building at the time the service is being rendered. So general supervision would apply in that situation. But the best practice is to always look at this publication because this is the most current information we have to date.
Yes, thank you for that. I know that the coding questions are a little bit hard to answer. And I think as you're referencing, it's always good to go back to your resource materials and what is written when you have a specific question, like a booklet like this is going to help guide with those coding questions as well. I think when you speak in generality, we have examples here with codes and they may not exactly apply to counselors or MFTs, the ones that were used in the slides. But like we're saying here, it's best to always go back to your documents and resources that CMS has provided for, practitioners to take a look at. So thank you for answering that. Another question that's come in is when submitting, and if you can answer this one, when submitting a claim, when do you use a CPT code versus a HCPCS code, if you will?
Well, CPT codes are probably going to be the most frequent for these two specialties. So usually a HCPCS code is for drugs and biologicals and maybe some temporary codes. So I would recommend using your CPT codes. That's where most of your coding will come into play.
Okay, so it sounds like the HCPC codes are more for
Other
special
service.
different kinds of services, that mostly what counselors and MFTs are going to be using are starting with those CPT codes. And then if they don't find what they need in that, then they may need to move to a HCPCS code, in other words. Okay,
Correct.
very good, very good. Let's see here. How about this question? Does Medicare limit the number of medically necessary counseling sessions, and what kind of information is required for authentication of that in a year? Can you all answer that? I know that's kind of a, I think we went through this the last time the Macs were here. Some questions are for Macs and some are actually CMS questions. So I know it's sort of hard to ferret some of that out. But can you all answer that question? How many medically necessary counseling sessions are allowed in a year for Medicare beneficiaries?
Well, that's where reviewing the policies and local coverage determinations come into play. Usually if there's a frequency, that information is contained in those publications. So that would be the best practice, is to review those for additional information.
Okay. Again, just going back to those resources, it's amazing. Like every time you have a question, if you can find it in writing and some of those resources, and you all provided so many of those, and I want to thank you for that in your presentation, because many of the slides have the links on them with the resources that you were describing. So if we can make sure, the people that are on the webinar, if you utilize those links, you will find, the answers to a lot of your questions. And I know it's difficult kind of sifting through, but they are there and they are available. So thank you for that. Another question, and I don't know if you'd be able to, I think this was probably along the same lines. Is there an out-of-pocket maximum for Part B services? Can you all answer that, or tell us how to find that out?
I'm trying to figure out if you're talking about the deductible. Like your patient would have to meet their deductible.
The person that asked the question didn't really ask that, but I guess you're right. Once they met the deductible, actually, right. If after they met their deductible, would there be, well, I guess there wouldn't be any more out of pocket, correct? That would be it.
Well, they would be responsible for the 20% co-insurance.
I guess they're asking, is there a maximum with that 20% co-insurance? Is there a maximum on that they would pay out of pocket?
That information would be included on the remittance advice on what the patient would be responsible for. So that would be the indication to the provider.
Okay, very good. Another person had written in asking, when does Medicare become the secondary insurance coverage?
Well, that's where the interviewing, when the patient comes into your practice, comes into play.
Mm-hmm.
So you need to make sure that you do check the patient's medical insurance cards when they come into your office. And that will tell you who's primary and who's secondary. You can also get that information through the MAC portals. HETS would have that as well.
Okay, very good. So you've given us some resources where we could make those determinations. And I know when you walk through, showing the picture of the Medicare card, which was very helpful, by the way, to have an understanding of what those cards are, especially for people that haven't actually seen the Medicare beneficiaries yet, being able to see those cards, what they're going to look like, what the numbers mean, and how they create those numbers and things like that. So thank you very much for sharing that.
And Jolie, it's Steph.
Mm-hmm.
I hope everyone can see, I'm not responding privately to those questions, so I hope they can see my response. But I did respond to that question and provided a resource that provides some scenarios and some examples of when Medicare is primary and when it's secondary, because I know seeing examples is always really beneficial. So
Okay.
hopefully participants can see that question and the answer and find that link. I'll see if I can find it again and put it to the chat.
Okay. Actually, was it in the Q&A box that you put it there?
It was, yes.
So participants should have access to that if it went into the Q&A box. That's great. Thank you. Thank you so much for doing that. That's wonderful.
Sure.
Let's see here. Let me see if there are a few more here. One person has written in saying, how might the submission process look different, if at all, for those of us who use credentialing entities? And they put some examples of those: Headway, Sondermine, Alma, etc., to submit insurance claims. Can you all answer that?
Well, there are various vendors that do have different output. So that could be what they're questioning. Maybe the output looks a little bit different. I don't know, Stephanie, do you have anything to add?
Yeah, I did respond to that one in the Q&A panel as well. And, you know, that's a little bit of a slippery slope for us to answer, because each of those vendors could be pulling in information from medical record systems that you could be using, or PETS, the eligibility system, etc. But I would say at the core of all of this, what we presented today should be the same across the board. You know, as far as pre-billing activities that you would experience, you know, CPT codes, HCPCS codes, all of that should be the same, modifiers, etc. So there shouldn't be any variation. It's just a dependency on what that vendor is going to prompt you to input to get a claim submitted.
Very good. Thank you. You know, I think that's going to be all the time that we have for questions today. And Stephanie, I'm sorry I wasn't looking in the Q&A box. I didn't realize you had responded to some of those as well. So thank you. Thank you so much for doing that. Like I said, unfortunately, we're out of time for questions right now, but I do think this has been, you know, a wonderful webinar with lots of great resources provided. The Medicare Mental Health Workforce Coalition and NBCC would like to thank Stephanie and Amy for sharing your knowledge and expertise, and to all the participants in the webinar today. The link to the session evaluation is posted in the chat, and we're also going to send you an email following the meeting with that link in case you missed that in the chat. To receive continuing education credit, you must complete the evaluation, and that evaluation includes the attendance attestation, by August 8th at 5 p.m. Eastern Time. The certificates will be emailed by August 15th, and we will only be providing credit for the live attendance of this webinar. We hope that you found this session informative. We look forward to seeing you again in the future as we continue our Medicare webinar series. Please be on the lookout for upcoming webinar dates and topics. And thank you all, and have a wonderful rest of your day.